My name's Gerhard Attard. I'm a medical oncologist in the Royal Marsden, and I run a team in the Institute of Cancer Research in London. And we focus on understanding treatment resistance in metastatic prostate cancer and developing tools to allow us to better select treatments for our patients. My lab recently has focused on using plasma DNA to perform these studies. We're able to collect multiple sequential plasma samples, and our recent studies have shown how we can leverage this sort of work to understand resistance. For example, we see emergence of an AR androgen receptor point mutation in 15 to 20% of patients progressing on abiraterone and PRED, and we've shown that that mutation is driving resistance in that proportion of patients. We've also shown that with a blood test prior to starting treatment, we're able to predict the chance of patients responding to abiraterone or enzalutamide by virtue of their plasma androgen receptor gene status. So we collect plasma DNA from patients, we sequence that, and we're able to detect specific aberrations in the androgen receptor. The chance of a man responding to the treatment with abiraterone, if he is AR normal, so there's no aberration, is 5 times higher for a 50% decline in PSA, and close to 8 times higher for having a decline in PSA by greater than 90%. And the hazard ratio for survival is 7.3. So patients who are AR normal are living 7.3 times longer if treated with abiraterone and a plasma AR normal versus those that are aberrant. What this of course introduces is how can we treat the plasma AR aberrant patients better, and we're now designing, and we've recently received funding from Prostate Cancer UK to perform a clinical trial where we prospectively randomize this group of aberrant patients between abiraterone, enzalutamide and chemotherapy, aiming to show that by doing that we will improve their outcomes and achieve better use of resources on the NHS.